Good afternoon, everyone. This is Pospo welcoming you to the second of the Mostly Learning webinar series, the Psychiatry of Pandemics. First things first, thank you. Really, thank you. I mean, we were all blown away by your response to our first webinar. More than 1,100 registrations. That's 1,100 registrations. But also for your generous and kind feedback. Nope. I can't change my accent, I'm afraid, but I am working on improving my Wi-Fi. Hopefully you can see and hear me better. So last week, we had Dr. Tom Pollack that took us through a journey from the Victorian times to the present, while linking infection, autoimmunity with mental health disorders along the way. And in fact, you can check the video on our website if you missed it. This week, though, we're going Corona all the way. And we will be focusing on coronavirus outbreaks because nope, we're not special at all. It all happened before. With me, Dr. Jonathan Rogers, a Wellcome Trust Clinical Training Fellow in the Division of Psychiatry at University College London, but also a Specialty Registrar in General Adult and Old Age Psychiatry here at the Mosley. Jonathan has a deviant interest in catatonia. I've seen him perform a clinical examination for catatonia, and I have to say, it's the best one I've seen by far. So if you're interested in catatonia, you should certainly check his Lancet Psychiatry publication, Catatonia and the Immune System. But no, he won't be talking about Mitgen, Gegenhalten under the Deutsche Woche, thank God. But he will be focusing instead on our tiny little friends, the coronaviruses. Just a reminder that we do follow a ask as many questions as you like policy, and we will try to answer most of them after the end of the session. So, welcome, Jonathan. How are you doing?
Thank you so much, and thanks for that introduction, Pospo. It's great to be with you all.
Fantastic. So, before we go into the juicy bits, can you please tell us a bit about the coronavirus itself? I mean, for a start, it's not one, right? It's a whole family.
Yeah, absolutely. So for the last few months, everyone's known about coronaviruses, but prior to that, you might not have heard of them at all. But they've been around since pretty much forever. They affect animals, they affect humans, and in fact, about 15% of the common cold is caused by coronaviruses of various sorts. And they've got catchy names like OC43, HKU1, NL63. All these different strands of coronaviruses. The virus itself is a single-stranded RNA, so it differs from the human genome, and there are lots of different forms that cause these different diseases, usually causing an upper respiratory tract infection. But obviously, once the virus has entered into the mucosal membranes, then it can get to other places.
Wow, that's a really big family with loads of weird names, I have to say. But you know what I'm more interested in is their effect on the brain. So are the coronaviruses neurotropic, meaning can they invade the brain? Can they invade the neural system?
Yeah, I think this is the million-dollar question really of COVID research, because we've all got very excited by this anosmia. A large proportion of people with COVID seem to lose their sense of smell, and this can persist for a few weeks after getting infection. But also, the bigger issue is the respiratory distress. Is that because the virus is down in the lungs and causing all this inflammation, or is it, at least partially, because the virus is affecting the brain and reducing our hypoxic drive to breathe? So this is a massive question. So what do we know about it? Well, other coronaviruses can occasionally invade the CNS. So we've known this for decades. Occasionally, in a young person, meningitis or encephalitis can be caused by a coronavirus. And you can actually isolate it when you do a lumbar puncture and virus in the CSF. This isn't at all common, and it tends to happen in people who are immunocompromised in some way. SARS-CoV-2, the virus that caused SARS, SARS-CoV, the virus that caused SARS, I can talk about in a minute, was found in a few patients in the brain. In terms of how it gets there, well, it's tricky. The virus that causes COVID-19 enters the brain through a receptor called ACE2, the angiotensin converting enzyme 2 receptor. And there are very, very low levels in the CNS. On the other hand, some recent work, I mean, this has just been published in the last week or so. If you grow neurons in the lab in a test tube, and then you insert the COVID-19 virus into them, it's been shown that they can replicate, they can grow inside a neuron. So I think there's a lot up in the air. We don't know everything yet, but we're getting some pointers.
Wow, okay, so that's really interesting. So there is evidence out there that yes, it can invade the brain. You know, it is fascinating how the world woke up one day under a new reality. You know, don't do this, don't do that, stay indoors. There's a virus you've never had before out there. And most people assumed that this is the first time that Corona has gone viral. The truth, though, that this is not the first coronavirus outbreak the world had to face, right?
Yeah, and actually it's quite fortunate for us because we're able to learn from these previous epidemics before we have this pandemic. So there have been two key ones you've got to be aware of. The first is SARS, the severe acute respiratory syndrome. And that started in 2002, went through 2003. That started in China. It was thought it was because a virus that had been around in bats for a long time managed to get into humans and that it could spread from one human being to another. Really terrifying situation, and had a mortality of about 10%. But crucially, we eradicated it, and we haven't had any cases of SARS since then. 2012, Middle East Respiratory Syndrome, MERS. This started, unsurprisingly, in the Middle East, in Saudi Arabia, and was later an outbreak in South Korea. Again, it was those wretched bats that were the culprit. But interestingly, although it originated in bats, it seems like actually most humans who caught it were catching it from camels, hence the Middle East link. And in many ways, MERS was even more scary than SARS, and that's for a couple of reasons. Firstly, the mortality in SARS was 10%. In MERS, it was 30%. The second thing is that although SARS was completely eliminated, MERS has had sporadic cases ever since. We've never had this massive outbreak again, but even looking in the literature as recently as 2019, there are a few cases of MERS. So yeah, definitely had coronaviruses before.
Yes, now I know that. Well, you know, I have my sources though, and they tell me that we have already submitted a paper, I don't know if it's already accepted, where we investigate the neuropsychiatric complications and consequences of previous coronavirus outbreaks. So were there any, in fact?
Yeah, so thanks for that. I mean, 4 weeks ago, I was twiddling my thumbs because I was trying to do this research project on catatonia, as you mentioned, and suddenly we couldn't recruit any patients. It was a disaster. So I thought, what can I do with my time? And I thought, actually, what about doing a systematic review of all the psychiatric and neuropsychiatric complications of these previous coronavirus infections? So it started small and got bigger and bigger, and we ended up finding it was over 2,000 articles, which we narrowed down to about 70 that we thought were really relevant.
2,000 articles?
Yeah, I mean, it was 70 that were really relevant for our purposes, but it covered 3,500 patients, and actually these people have been followed up, in some cases, up to 12 years. And so we've got some really good data out there. In terms of what we found, it was really quite interesting. So if you look at the acute phase, and when patients are physically unwell with SARS or MERS, it seems that about 20, 30, 40% of them are getting things like insomnia, confusion, altered consciousness, poor attention, things that as a liaison psychiatrist make me think about delirium, this acute confusional state. And delirium has become a little bit sexier in recent times, but I think it's really important because it means that patients have a prolonged hospital stay, prolonged recovery, and potentially even lasting cognitive impairment. I suppose the big question here is, are we seeing the same thing with COVID? And in the last week or so, some authors from Edinburgh and Liverpool, led by Doherty et al., have published a massive case series of UK cases. 11,000 patients come into British hospitals, and confusion features in 20% of these cases. So I think we're seeing just as much delirium really with COVID-19, at least in the patients who come to hospital, as we were with SARS and MERS. Anecdotally, I'm seeing cases of COVID delirium. It seems to be quite prolonged, and people can take a while getting better from it. So this is a huge problem. The other thing it's worth mentioning is that that's what happened acutely. But what's really interesting is that SARS and MERS seem to have effects beyond the couple of weeks or so when people were physically unwell. There seem to be delayed neuropsychiatric consequences. So the four main ones were fatigue, about 20% of patients, anxiety disorder, 15%, depression, 15%, and PTSD, just over 30%. So, I mean, this is huge. You're run over by a bus and you think all you need is your surgery to get better. But actually, this can affect you for months, even years later.
So, I mean, I'm hearing talk about, about anxiety, about fatigue. I mean, sometimes, as you said, low mood. I'm thinking to myself, so wasn't that expected? I mean, if we were to study a different pandemic of a different virus, so not a coronavirus, so would we find different results? Or is there anything specific about this one, about the coronavirus family, that it makes it so special?
Yeah, I think you're absolutely right to be skeptical and cautious in the way we interpret this. If you look at any patients who are admitted to an intensive care unit, there are high rates of depression, anxiety, and PTSD just from the fact that you had a tube stuck down your throat, it's been taken out, you've been confused for months. But I think what's distinctive about coronavirus outbreaks is that so many people are going to ITU. We've never had this in the history of the world where so many people have been in an intensive care unit, and we don't know what the outcomes of that are going to be. I mean, it's not like influenza where a small proportion of old people tragically die. This is young, middle-aged and old people in intensive care. And I think also one point that came out reading through the literature is that what's a little bit distinctive about COVID is that rightly there's so much infection control, but this means that patients with COVID are incredibly isolated in hospital. They're in their cubicle, they can't speak to other patients, they can't speak to nurses. And what we're seeing with older, confused patients, they're getting very upset because they can't speak to their family members, they can't have visitors coming in, which is I find one of the main things that helps people with delirium and dementia to feel a bit more comfortable in hospital.
That's really sad and really difficult to deal with. So you did talk a lot about delirium, and we do know that it is a distinct entity from psychosis. But is there any evidence though that links coronavirus, so a virus that can clearly invade the brain, psychosis and not delirium?
Yeah, I think that's really interesting. So some of my colleagues have said that they think they're seeing a number of acute transient psychotic episodes that may or may not be COVID related. In terms of what we have from the previous literature, about 1% of patients with SARS seem to experience psychosis. It's small numbers, but a case of about 15 was studied, and the presentation varied. Some were frankly manic, others had quite systemized delusions, and others had psychotic depression, and they're all seen by liaison psychiatry, which is great. So we've got a bit of information about what's going on with them, and 13 out of those 15 were diagnosed with a corticosteroid-induced psychosis. Now this is interesting because steroids were used much more for SARS than they are being for COVID, and there's some evidence that actually in COVID they're associated with a poorer prognosis. but they are being investigated. So the recovery trial, which is running out of the UK, is using steroids in one of the treatment arms. So it is possible that we'll see some corticosteroid-induced psychosis. The other really interesting thing in this study is that actually the steroid doses between the people who got psychosis and the people who didn't get psychosis weren't that different. So maybe there is something else going on. Maybe there's a predisposition in the people who got psychosis. And when they really delved into this, they found that those patients with a family history of psychiatric disorder were more likely to get this so-called steroid-induced psychosis. I think the other thing that's probably relevant when we're thinking about psychosis is that we're seeing over the last few weeks, I mean, it's starting to pick up now, but we're seeing fewer people come into A&E with mental health presentations. And I do worry that actually there are going to be people who've been developing a first episode of psychosis or a recurrence and who would normally be getting prompt psychiatric treatment who aren't presenting now, and we may have a lot more people in a few weeks' time.
So what I'm hearing essentially is that yes, there is psychosis there, and there is the part that, let's say, the iatrogenic cause, so that, we give steroids to treat COVID and then people get psychotic, but also it sounds that there is also a predisposition. So people are predisposed to develop psychosis and have higher chances of developing an episode during this pandemic. Now, going through the literature, I found some particularly interesting findings from qualitative studies. So what they did is that they assessed the longer-term outcomes for patients with SARS, because, although we are indeed focusing, and rightly so, on what's happening now, the truth is that all this is going to come to an end sooner or later, at least I hope so. So what are these longer-term outcomes that we are expecting to see in the future?
Yeah, I mean, the qualitative data is really interesting because you get a lot more granularity about what people are actually experiencing. And looking back on their experiences, a lot of people talked about worry at the time. The social isolation was really, really tough. So people were lonely, they were bored, they were frustrated. And also there was a huge amount of uncertainty. They didn't know what was going to happen. Like today in China, Hong Kong, Saudi Arabia, there was a lot of media coverage about SARS and MERS. So people were worried about, is this a curable illness? Can we get better? And actually also there was the same concern we're seeing now about the accuracy of the information. Do the doctors know what they're doing? Is the media reporting correctly? The other thing that people were really worried about was, have I infected my family members already? What about when I get better? Will I infect them then? So that was some of their concerns looking back. But it's also really interesting to think about, what about a couple of months, even a couple of years later, what were these people experiencing? And the main finding that came from a couple of these studies was stigma. We talk about stigma in mental health, but actually it's really relevant to a number of physical health conditions as well. So with SARS, people said that they experienced stigma from relatives who, even months after they'd recovered, didn't want contact for fear that they'd contract the illness. There was also institutional stigma. So you not being allowed inside a public library, or not being allowed to sit in the same outpatient clinic as other patients. And finally, most surprisingly, maybe most concerningly, a number of patients talked about stigma from clinicians. And this relates to what we were saying earlier about the delayed consequences of severe coronavirus infection. So clinicians accepted, yes, you had this severe respiratory illness, but there was an expectation that they would have got over it, and that would be it. But what the longer-term follow-up studies have shown, and they've now kind of backed the patients up, is that they were having delayed respiratory symptoms and also these delayed neuropsychiatric symptoms, which initially clinicians were quite dismissive of.
Well, it seems though that this is not an entirely, doom and gloom situation. I mean, there have been the reports of some weirdly positive outcomes too from all this, right?
Yeah, surprisingly, actually. So patients talked about really appreciating the care that they've been given. then, as in now, actually, there were a number of healthcare professionals who became unwell with SARS, and they said that actually it gave them this unique ability to see things from a patient's perspective, as well as from usually a nursing perspective. A number of people talked about how much they valued the support from colleagues, friends, and family. And quite interestingly, looking back on their experiences, patients said that it had given them a better perspective in life. So actually, they valued the everyday things more. They really valued and appreciated being healthy in a way that they hadn't done before the outbreak.
And what about the the current pandemic? I mean, the one that we're going through right now. I mean, I know that it may be a bit early to say, but is it any different to the previous one? So looking, because we did this amazing review. So looking back in all the outcomes from the previous SARS and MERS outbreaks, what's your gut feeling about this one? Is it any different?
Yeah, I think that's important. In terms of the pathophysiology, the virus, so SARS was caused by the SARS-CoV-2 virus. It was caused by the SARS-CoV virus, and COVID-19 is caused by the SARS-CoV-2 virus. They're very similar, actually, and much more similar than MERS was. But the mortality is a lot better for COVID-19. So unlike in SARS, it was 10%. In COVID-19, the CDC gives estimates of between 0.25% and 3%. However, if you look at the mortality among patients who are admitted to hospital, or the rates of being admitted to ITU, or those who go to hospital, it's actually quite similar to SARS. So I think we can probably extrapolate a little bit to people who are well enough to be admitted to hospital. I think it's a very open question what will happen to patients who did have COVID-19 but didn't make it to hospital. I think there are probably a couple of other differences as well, which may be advantageous or may not. The first is the global reach of these. SARS and MERS were terrifying, but they were really quite local. But I think the fact that so many people are getting COVID-19 might mean that there's not as much stigma. If everyone knows someone who's had it, it will be hard to really stigmatize people who've had it.
So there was this, the really recently published paper on JAMA, by Ling Mao and team. So what they did, so they looked into the neurological manifestations of hospitalized patients with COVID-19 in Wuhan, where it all started. So it is really interesting to see, though, that for some patients, neurological were the only symptoms they displayed. No fever, no cough, nothing that could remotely resemble a typical COVID-19 patient.
Yeah, this paper was really interesting and has shaken the COVID world a little bit, I think. I think it's important to note that although they did find a lot of neurological symptoms, 30% or more, lots of these symptoms were things like headache, dizziness, and anosmia, which may well be the signs of a primary neurological disorder, but very often they appear in respiratory disorders. So with the anosmia, for instance, it might just be that there's inflammation of the nasal mucosa, and that's why you can't smell, like you sometimes get it in coryzal symptoms. Headache and dizziness, again, really common in systemic illness. There were a few cases of something much more specific. So it looks like there's some hyperviscosity in COVID-19, and there were higher rates high rates, relatively speaking, of ischemic stroke, although it still wasn't common. What you said about the patients who just had the neurological symptoms is really interesting, and that they did notice this inverse relationship between patients who had neurological symptoms and patients who had the typical respiratory symptoms. So maybe there is this well circumscribed subtype of COVID where they have a more CNS presentation.
So I think that then, what I will keep from that, so the take-home message is that, for people that present with an exclusively neurological presentation nowadays, maybe COVID-19 should be, in the differential. So when this is all over, I can't wait to tell you the truth. So what should we be expecting for patients that survive the COVID-19 ordeal? So are there any risk factors for poor psychiatric outcomes? I mean, previously, so in past outbreaks, you did mention that people did manage to resume normality, including even going back to work. So what are we expecting for our patients today?
Yeah, so the majority of patients did get back to work. I think the big four to be aware of are depression, anxiety, PTSD, and fatigue. And I think the fatigue I'm already hearing from colleagues can be a little bit delayed after COVID and can be a bit prolonged. But in terms of who's more likely to have these features, a few of the symptoms were the things we were expecting. So the patients who were more likely to have adverse psychiatric outcomes were the patients who had a more severe COVID illness, had more pain, more worry, maybe experienced the death of a relative. A couple were a bit less expected, actually. So if you were a healthcare worker, you had a higher risk of adverse psychiatric outcomes, which is really important for us to be aware of. This is a high-risk group. Patients who are having frequent recall of memories about SARS, again, seem to be at higher risk of developing adverse outcomes. And also patients who had some degree of medico-legal involvement. So I think there are red flags that should make us ask proactively as clinicians when we see patients who've had COVID about psychiatric consequences.
So true to tradition, Jonathan, I'm going to finish this webinar with the same final question for the £2 million, no way to get any pounds from me. So a virus making you depressed, anxious, and potentially psychotic. Is this therefore the final nail on the coffin for the mind-body dualism supporters?
Well, it's interesting you asked that, actually, because when we were writing the review, we decided we wanted to do a really specific neuropsychiatric review of the consequences of this virus. And in the end, we just concluded it was absolutely impossible, because you couldn't distinguish what's the virus, what's the treatment for the virus, what are the psychological consequences of severe illness, what's the sociology of being separated from friends and family, and what about the unemployment, the financial difficulties. So I think you're absolutely right. And this is another nail hammered into the coffin of that mind-body dualism.
Thank you so much, Jonathan. That was fascinating stuff, man. So congratulations also on your new paper. People can access it through Lancet Psychiatry, because there are so many things that we can learn from the past. Now, if you also want, though, to inform the future, keep in mind that you can report neurological and psychiatric syndromes associated with suspected or confirmed COVID-19 infection on the coroner surveillance study. So what about us? Are we meeting again? You bet we are. Join me next week. Yes, same day, same time. Tuesday at 1 p.m. With me, Dr. Shivon G. We will be shifting our focus to psychopharmacology and how this awful virus brought things upside down. Is there a role for a psychopharmacologist in the multidisciplinary team? Should psychiatrists change their prescribing practices? And what would happen if they don't? I've been receiving already loads of questions for clozapine related matters. Be patient. It's only 1 week. Pospo for Mostly Learning, over and out.